It is now my privilege to introduce our moderator, Casa Darje, MD, PhD, DTM and P, FSAR, FAUIM, Radiologist in Chief, William L. Van Allen Endowed Chair, Department of Radiology, Children's Hospital of Philadelphia, Professor of Radiology and Surgery, Perelman School of Medicine, University of Pennsylvania, Philadelphia, Pennsylvania. Dr. Dargay.
Thank you very much, Matt. Let me share the slides also from my part and share. And I just want to start off by saying welcome to all the attendees. And on behalf of the International Contrast Ultrasound Society and our co-presidents, Dr. Feinstein and Wilson, I want to extend a warm welcome and also thank Northwest Imaging Forums for organizing this and providing this CME. What is the International Contrast Ultrasound Society? And this is really the only global professional society solely focused on contrast enhanced ultrasound and with members in some 74 countries incorporating physicians, sonographers, nurses, scientists, industry, and patients, and across subspecialties of radiology, cardiology, hepatology, vascular and GI imaging, and many more. And the society is really committed to CEUS and regards contrast-enhanced ultrasound as an essential tool for modern ultrasound labs, and that is clearly produces high-resolution real-time imaging in echocardiography, and also as an imaging modality that often reduces downstream testings. And the ICUS is committed to the CEUS educations for all health professionals, a lot of educational opportunities in the calendars that you can register for, and also live webinars are recorded and are available on the ICUS websites and ICUS Connect. So for ICUS, one thing is really unique. The membership is free. That it also provides free CMEs, free website, free mobile app, and free CEUS news monitors. And I will talk about these separately. The website is really one of the most comprehensive websites when it comes to contrast enhanced ultrasound, with a lot of webinars, educational information, protocols, and training materials, including reimbursement informations. There are extensive exhibits, product informations, and also sponsor websites related to contrast-enhanced ultrasound. And ICUS has also built this really interesting app, ICUS Connect. This is really a convenient tool for CEUS. You can have it on your phone and get the protocols and guidelines, coding information, product labels and information, and training hub, and much, much more. And all this is for free. I personally love the CEUS News Monitor, which you get really every week. And why I love it is because I'm always surprised. They find out publications that I had not seen yet. And really, then I go to the original publication to find out more information about new things, including pediatric aspects. So this is a weekly news monitor that you get for free and provides a lot of information, including the new publications. And it's English, and our colleagues have also now translated it into Mandarin, and it's available in that language. Very interesting for our sonographers, and we as a department, we have to be aware that there is a whole curriculum for training sonographers with a lot of plug and play modules for sonography training, a lot of information, and it's really developed by a joint task force that involves the professional societies of the sonographers, both in echocardiography and general sonography. So this is really an information that we need to share with our sonographers in the department. There's also further an IV training and certification modules for echo and general imaging sonographers, IV training webinars, hands-on IV training, which is promoted by ICAS, and then certification jointly by ICAS and Intellios or ARDMS. This is really important. This is to allow to be sonographers independent, to be able to examine the patient, inject the contrast, and do contrast enhanced ultrasound. So that information is really coordinated and something that was missing for a long time, but now is available. So something you can share with your sonographers. And just recently in February of this year, the ICAS came up with a multi-societal expert consensus statement on the safe administration of ultrasound contrast agent. Was the purpose of this document was to empower institutions to allow sonographers, along with other trained medical professionals, to administer ultrasound contrast agents at the point of care, which was consistent with the updated SDMS scope of practice. So this is something really further enhancing the independent ability for sonographers, to empower them to be able to do the studies, facilitate and support the radiologist or cardiologist. The ICAS has this barcode that you can scan. There is Instagram, there is Facebook, and you can be involved in all these discussions. All this would not be possible without our really generous sponsors. Bracco is the diamond sponsor, GE the platinum, Lantheus is the gold sponsor, silver sponsor are Siemens Healthineers, Canon, and Sonoscape, and bronze sponsors are Dentons, Fat Roman Studios, Northwest Imaging Forums, and Live Media. And really thank you to all our sponsors of ICAS. You make it possible to provide all these really amazing informational tools, educational tools for free. Now going to the agenda today, it's my great pleasure to see the Children's Hospital of Philadelphia, particularly the Center for Contrast Ultrasound here in our institution lead this presentation. The Center for Pediatric Contrast Ultrasound really is established in around 2017 with the aim to enhance clinical service, education, and research of contrast-enhanced ultrasound at the Children's Hospital of Philadelphia. And now we have really closed the loop with our cardiology partners. So now we're doing contrast-enhanced ultrasound from head to toe, including cardiac imaging. So we have the whole gamut of pediatric contrast-enhanced ultrasound at CHOP, and use it for various indications with the intravenous route, intracavitary, which includes also intravesical. We do interventional. All our interventional radiologists do contrast-enhanced ultrasound. And also we do intralymphatic. So we do 4 different routes for various indications. And contrast-enhanced ultrasound is not limited to 1 or 2 people doing it. All members of the Division of Body Imaging, more than 30 colleagues, do contrast-enhanced ultrasound, as well as about 24 of our sonographers. We offer it also at our satellite stations. Our interventional radiologists, all of them, about 7 of them, do contrast-enhanced ultrasound for interventional processes, as well as our Center for Lymphatic Imaging and Therapeutics. They use contrast enhanced ultrasounds in novel intralymphatic applications. And our cardiologists have now really joined forces and have started using contrast enhanced ultrasound also for echocardiography. So we are really happy to have all of them present. This is more focused on workflow, how to make it better, how to specifically address some pediatric issues, but certainly this can be used for adult imaging also. So without further ado, it is my great pleasure to pass on an invite for the first presentation, Dr. Susan Back, who not only holds the directorship for the Center for Pediatric Contrast Ultrasound, but has also at CHOP the endowed chair for pediatric contrast ultrasound, is also the director for the section of genitourinary imaging in the department. To start with the first lecture, and then she will guide us through the other presentations. Thank you very much.
Thank you very much, Casa. Thank you. And hello, and thank you to everyone who's joined us today. We'll be sharing steps with you that we took and continue to take to establish contrast ultrasound at our center. And I'll specifically be giving you the perspective of the radiologist. So I do have the disclosures listed on this slide. Why are we doing pediatric contrast ultrasound? Well, starting a new imaging service is an extra effort on top of the work that each of us are doing every day. And because of this, it's important to remember why we do it. It's not only an excellent diagnostic and troubleshooting tool, but it has great benefits for children, whether it's avoiding sedation or keeping them safe while they're being imaged, as my colleague will go into later, or just keeping the child close to their parent or caregiver to keep them comfortable during the exam. And I'll give you a couple of other examples here. So for these two different patients with tumor predisposition syndromes, they undergo routine surveillance imaging looking for the development of tumors. And for each of these children, they were found to have a new lesion. With contrast ultrasound, we can get very quick information about each of these lesions. And the one in the right hepatic segment that you see here had washout on the venous phase and concerned us for malignancy. We're able to quickly expedite the care of this child to get further imaging and diagnosis, which was ultimately a hepatoblastoma, in comparison to the other child who had more benign features, and we were able to continue to surveil by ultrasound. Contrast ultrasound is portable, which is really important, especially in our ICUs. This child was a 19-day-old premature infant who was critically ill. When they were born, they had urinary tract dilation and perinephric fluid. They had ascites, and we could not identify their urinary bladder despite multiple attempts at routine ultrasound. Because of their clinical status, it was very difficult to mobilize them to the fluoroscopy suite to assess their urinary tract. But we could bring contrast ultrasound to the bedside and show that the urinary bladder was intact, the urethra was normal, there was no lower tract obstruction or reflux, and that could help their care team take the next steps in management. So how do we start? Well, first you need the equipment to do the examinations, and most ultrasound scanners used in imaging departments have the capacity to support contrast ultrasound. So the first place to go is to talk to your ultrasound vendors and see what's available and what you have or may need to equip your current machines with contrast software. If you're already imaging children, chances are you already have the transducers that are most commonly used for contrast ultrasound and are supported with contrast software. And the vast majority of the work that we do are done with one of these transducers, so a lower to mid frequency range convex transducer, one at least linear probe, and the microconvex, especially for our small infants and smaller children. Next, you'll have to determine which contrast agent you use. The CEUS Society has a wonderful map that's interactive. If you were live on their site and hovering over your area by country, you would be able to see which contrast agents are available to you commercially. If your institution is already imaging adults or using contrast ultrasound for echocardiography, you may already have an agent on your institution formulary. Here in the United States, there are 3 commercial agents that are available. So one being sulfur hexafluoride lipid type A microsphere or Lumason, perfutrin protein type A microsphere or Optizin, and perfutrin lipid microsphere or Definity. So each of the agents differ by their inert gas, the shell that stabilizes them, the bubble size and concentration, which may have slight differences in the way that they image, but you could work with your ultrasound vendor and the contrast agent company to help with the aid of your application specialist to optimize your imaging so that you can set it up in your lab. Currently, these 3 agents, all available in the US, each have FDA approval in echocardiography for children. And one agent has additional approval for the intravenous use and assessment of focal liver lesions in children, and the other for vesicoureteral reflux. Everything else is considered off-label use, so it's important to think about that for a moment. An off-label use of an agent, in this case a contrast agent, is using it in a way that it is not labeled for use as in the package insert. And physicians use agents and biologics and devices routinely in medicine with their knowledge and judgment to apply to the care of the patient. And this is no different for contrast ultrasound. So using an ultrasound contrast agent off-label will mean that we're looking at a different body organ, a different body cavity, or we're changing the dose. But I think one thing that is important, and we've found in our own experience, is that we can image just about every abdominal organ in a child using the same dose that we would for the liver, which is a packaged indication. So essentially that means that we are injecting the contrast agent and putting the ultrasound probe over a different body part. So this gives us great confidence that we can do this safely. And according to the package labeling in most indications. However, we do a fair amount of off-label use. As you consider what indications you will do at your center, you will have to look into what your institutional requirements are, because some places do require approval and consent for off-label use. As Dr. Darge had said at the introduction, our institution has a number of ways that we've applied contrast ultrasound, not only through intravenous, but intracavitary, lymphatic, and in the interventional lab, which you'll hear about shortly. As this list and our imaging requests have grown, we periodically have to review our exam orders and build new ones. And we're currently undergoing that review now. So this is a list of sort of the revised image orders that we have created and make available to our referring providers. In this way, they can very easily recognize the option that suits the needs for their patient. And it also helps us with our own internal team communication, so we know what's needed for each examination. Behind each of those orders, we have the billing set up according to the current procedural terminology, or the CPT codes, which essentially links each order to a limited charge for the respective body region, plus the administration of contrast. If we do give an additional dose of contrast to look at an additional lesion or focal area of the organ, we can add on an additional charge. Similarly, we have the CPT codes bundled for exams such as our voiding contrast enhanced ultrasound, and that's all within the background of each of these orders. When you start to schedule examinations, you have to think about how this works best within your department. Some people find that it's best to offer exams on certain days or times of the day. In our own center, we have 5 contrast ultrasound slots daily at our main campus, where we do the majority of our contrast work. And that way we know we've protected the time of the radiologists so that they can be in the room for each of those examinations as they need to be. In order to integrate contrast ultrasound into the department in general, we found it very useful to parallel the way other modalities were running. So for example, since we need an intravenous line for a lot of these examinations, they're placed by the same nursing team that supports CT and MRI. Similarly, in our workflow, when we have to evaluate contrast screening forms for possibility of allergic reactions, then we've added ultrasound contrast to that screening form so that everybody is very familiar with this workflow, and you'll hear a little bit more about those forms in a later presentation. In order to have consistency and to support the workflow, having documented protocols and procedures has really helped further the care of our patients. So these documents are available institution, health system wide, and they include equipment lists, step-by-step instructions on how to image, what images should be acquired, and special considerations for some examinations. And one way that these documents have particularly supported the expansion of our service is that having them available to the bedside nurses and intensive care unit nurses means that they are able to help us with these examinations and at times help us administer the contrast ultrasound agent so that if we don't have additional team members to send to the bedside, they can help us there. Finally, once you're ready to go, you have to build your referral base. And so I think the best way to do this is to reach out to the teams who take care of the patients for the indications that you're ready to offer. As you build these relationships, you show them the exam success stories, you show them exams where it's really been beneficial. You bring these cases back to your multidisciplinary conferences. And as a benefit of being a radiologist, you have the opportunity in your report, if you recognize a moment where contrast ultrasound could further the care of the patient, to put it in your imaging report. All of these efforts will be furthered by the continued integration of contrast ultrasound into societal imaging discussions and practice parameters. And here are just a few of more recent updates, all of which mention contrast ultrasound as an important modality in the assessment of pediatric imaging. So in short, it's important to first consider how you're going to get the equipment into your department, to establish the protocol development with workflows, develop clinical partnerships for those patients you think will benefit most first, and you'll see quickly it will expand to other patients you might not have even thought of. And I think with at larger, if you have a position on an imaging society or networks of physicians, to keep the conversation and be an advocate to have it entered into current practice parameters. So thank you very much for your attention. I'm happy to take questions at the end or by email. And at this time, it gives me great pleasure to introduce my colleague, Trudy Morgan, who is a co-director of the Center for Pediatric Contrast Ultrasound at the Children's Hospital. And she is going to share with you the sonographer's role in setting up a successful contrast study.
Hello, and thank you for having me here today. During my talk, I will go over some of the responsibilities for the sonographer to help create a successful contrast study. These are my disclosures. Some of my objectives will be education of the sonographers, ways to learn contrast, and the backup resources that make this learning easier. Patient preparation from scheduling to scanning, including patient support, what our injection process is and what we look for, and I will touch briefly on the supplies and scanning protocol. Education is key to developing a good contrast program. When we first began ultrasound contrast, we thought the radiologists would be the ones to initiate this learning, but we soon found out that the sonographers were a better fit. You will need some key players. These will be your core sonographers. These may be your more seasoned and experienced staff who are willing to take on the challenges of growing the department. Once they are certified in doing contrast ultrasound, they will buddy up and teach other staff members. Some ways to educate your team is having learning tools in place. It may be good practice to have learning sessions in designated meetings. These meetings can include teaching by tools like cup scanning and phantom scanning. These will help your seasoned techs refresh protocols and your more novice techs get familiar with ultrasound contrast in a non-clinical setting. Next, we have one-on-one simulation training where a certified sonographer will sit down with a novice one and go over all the steps from setting up the study to ending the study. We have PowerPoints or other education material to have up as a backup source. And it's always good to have protocols available for your staff. And speaking of those protocols, our ultrasound team lead has sat down with our contrast radiologists, and they collaborated to create protocols that help communication with the sonographers as well as the referring clinicians. This makes our service clear and less confusing. Now it's time to prepare for our patients to come for their appointments. We do things preemptively to make sure that everything is complete for when they arrive on the day of their appointment. So we look up scheduled cases ahead of time to check if the a correct order was placed. Sometimes this is not the case, and it gives us time to reach out to the clinicians to confirm what they need. Next, I usually send out emails and messages a week ahead of time to all pertinent staff who will be involved in the cases. This helps put these patients on the radar for everyone. And then we want to make sure that the radiologist places the contrast orders ahead of time. Once we've done our legwork, it's time for the patient to come for their appointment. NPO is not needed for most ultrasound contrast. These exceptions are for bowel and gallbladder. They should be performed preferably in the morning before eating or after 4 hours of fasting. Our hope is to reduce peristaltic movement and the amount of intraluminal air in the bowel, and to prevent the compression of the gallbladder itself. Always ask about allergies. Like Sue said, we have forms that we ask about allergies in general, and if any patient has had allergic reactions to other contrast media. Depending on the type of contrast agent you may use, you may be more specific about allergies that may be related to the makeup of that particular contrast. And then you want to explain the procedure to the family. And depending on the child's age, we can use child life to aid in describing the study. We have many distractions here at CHOP, but in most cases, parents are going to be your best friends. They know their child best. But here's a list of distractions that help with us. Bluey happens to be a favorite among children as well as adults. But you can see this list of different things that help and aid in distracting the child to get through the study easier. If you find that these things do not help, you can always rely on your child life team. Child Life is a team that aids engaging children in day-to-day activities and to cope with the hospital experiences. These wonderful humans can be your best friend. We are lucky enough to have a Child Life group that is dedicated to radiology, and they can be available for any specialized study. For contrast cases, Child Life is usually scheduled ahead of time, but can be available on demand. This is the reason I send out emails ahead of time so that they can be aware of patients that may need their assistance. These are the commercial ultrasound contrast agents that are utilized today. All agents create quality imaging, and depending on the contrast agent on your formulary, you will utilize the method given on how to reconstitute the agent and determine the required dose according to the literature. So we'll talk about the injection process. IVs are usually placed by our sedation team or an IV team. We typically send the outpatients to get their IV at the sedation unit, and then they come over. We do pre-scanning and then set up for the contrast study. It is always good practice to go over the case with the radiologist, since there are times that we do the scan before the IV is placed in case we don't need the IV. It can be a peripheral or central line. We prefer it to be on the left side because we scan from the right, but it can be placed wherever is needed. And it should be 24 gauge or larger. Although that the patient might have just gone over to get their IV, we always make sure when they arrive in the ultrasound department that we check that it's working. So we clean the IV according to hospital standards, connect the saline flush to the IV, make sure that you unclamp it, because you don't want to cause pressure on the IV by trying to send fluid through a clamped IV. If there's pushback, contact the nurse to assess the IV for infiltration or if it needs to be replaced. And then once patency is confirmed, we can get ready for the contrast study itself. One of the major mistakes during a contrast study is for the contrast to be placed on the incorrect port. You always want to make sure that the contrast is placed straight into the line and the patient. Because if you have it on the 90-degree port, it can cause bubble destruction. Here's an example of when that happened. We had a patient who originally came, and we had a nurse who was new to contrast helping us inject. We didn't realize that she had put the contrast on the 90-degree port. And as you can see here, we don't have very good bubble flow. And once we figured out what was wrong, we set it up correctly and did another injection. And now you can see how the flow comes in nicely. You can see the kidney and the bubbles fill. Though the contrast agent is a very important part of the study, you will need an ultrasound machine to image the contrast. These are some of the major vendors that produce contrast ultrasound. They all produce quality contrast, but they all have their own way of doing it. Like Sue said, if you don't have contrast on the machine itself, you can always reach out to your vendor and go over what you would need to perform ultrasound contrast. This is just a list of the major buttons that you would need to be to recognize for ultrasound contrast. Some of them are universal, and then some of them are vendor specific, like the contrast clock and the timer. They mean the same thing, but depending on your system, they may be different words. So just become familiar because they will be important for ultrasound contrast. It is a minimum of a 2-person exam. One performs the ultrasound, that is usually the sonographer who's doing the scanning, and one injects or instills the contrast. It would be very difficult for one person to perform both studies. This is just a list of the contrast supplies we have for CEUS. One of the main things is to make sure that you have a crash cart available in case there is anything unexpected that would happen. We gather these items together and set up the room before the patient arrives. This is just some highlights from our protocol for CEUS. One of the major things is to have strong communication between the scanning sonographer and the injection person. This will make for a successful study. Once the injection is begun, the scanning sonographer will hold position over the area of interest for at least 60 to 90 seconds. After this initial clip, you can do clips or stills like every 30 seconds for up to 5 minutes or longer, depending on washout. We will look for changes to help delineate between benign and malignant lesions. This again is our supplies and our room setup for CEUS. And then this is just a brief overview of our protocol. In a continuous fashion, you're going to image the bladder, right kidney, and left kidney. If prior reflux is known, or if one kidney is at higher risk, you can always go the reverse way. But you're going to continue in this fashion until the bladder fills, or if you see reflux and the child is ready to void. So our take-home points today are: education is key to beginning any contrast ultrasound, because if you do not learn how to do it, you can't have a successful program. Standardized protocols will help facilitate better communication, starting with the ordering clinician down to the radiology staff. Protocols make the study process easier and less confusing. Always evaluate the IV line prior to any injection. This will help not cause any harm to the patient or make any problems with your study. And then follow the protocol. Make sure that your doctor as well as your staff members know what the protocol is and follow it from start to beginning. Thank you for listening to me today. And again, we will take questions at the end, or my email is here if you have anything more in depth to ask.
Thank you very much, Trudy.
Okay.
Now I would like to welcome Dr. Katerina Dulia to share her slides. She is a pediatric radiologist and researcher, and she's going to be speaking to us about contrast ultrasound, clinical service quality, and safety. Katerina, just make sure your microphone is unmuted.
Yes, thank you. Thank you, Sue. Thank you so much. Hello, everybody. I have nothing to disclose. So when we think about clinical service quality and safety of a pediatric contrast-enhanced ultrasound service, we want to think about maintaining a standard. In other words, how do we consistently perform diagnostic and safe CEUS exams? What systems and processes must be in place to make this possible? In the previous presentations, Dr. Bach walked us through the steps that our department followed to set up a pediatric CEUS service, from clinical indications and appropriate use to standardizing imaging protocols and gaining support from subspecialties outside radiology. Then Trudy outlined the technical aspects of the procedures, how to perform diagnostic CEUS exams, and how our workflow looks like. In this presentation, I'm going to focus on the safety side of our service. I will cover what we need to know about the safety benefits of ultrasound contrast agents, what types of adverse events we can expect, what is the experience at CHOP on safety of CEUS exams, and what steps we have taken in our workflow to ensure that CEUS exams are performed safely. Ultrasound contrast agents have tremendous safety advantages and are among the safest contrast media. They are not excreted by the kidneys, so they are not nephrotoxic. We don't need to check renal function prior to use, and they can be safely administered in patients with renal failure and those with renal transplants. In most cases, just like standard ultrasound, CEUS exams do not require sedation, and they can be performed right in the ultrasound department, or we can take the scanner to the bedside, or down in the emergency room, or up in the intensive care unit, or even intraoperatively and perform CEUS exams portably. This accessibility is especially valuable for children who can't travel to the ultrasound department or are unable to undergo CT or MRI due to sedation risks, for example. Over the past few decades, a large volume of safety data has demonstrated that ultrasound contrast agents are well tolerated and have a very good safety record. In fact, the vast majority of children undergoing CEUS exams do not have any symptoms at all. Very rarely, serious anaphylactic or hypersensitivity reactions can occur, and they have been reported with the IV route of administration. Such allergic reactions may present with a range of symptoms, including skin flushing or generalized rash, swelling of the lips, tongue, or face, respiratory symptoms such as cough, wheezing, or difficulty in breathing, GI symptoms like vomiting or abdominal pain, and systemic symptoms such as low blood pressure or general discomfort. While these events are exceedingly rare, they can be potentially life-threatening and require immediate recognition and response. Particularly in pediatrics, recognizing an adverse event can be challenging in young children who cannot articulate how they feel, and in those undergoing scans in prone or lateral positions where visual contact with a performing sonographer may be limited. For that reason, it is essential that the second team member, usually present in the room, to look at the child. In the pediatric literature to date, more than 5,000 children have been reported to have had approximately 5,700 intravenous injections of ultrasound contrast agents. The reported rate of serious adverse events from the IV use of ultrasound contrast agents in children is 0.2%. That corresponds to 10 serious reactions out of 5,000 children. Of the 10 serious adverse events reported in the literature, 7 cases were anaphylaxis or severe hypersensitivity reactions, and 3 cases were episodes of hypotension. All events occurred either during the injection or shortly after and required immediate resuscitation. All cases were successfully treated with no fatalities or illness being reported. The table on the right is showing the publication that reported these serious adverse events and the age and gender distribution of the affected children. Compared to contrast agents used in CT and MRI, ultrasound contrast agents have a similarly very low incidence of allergic reactions, as we can see from these 2 large-scale pediatric studies. However, beyond the risk of allergic reactions, with CT and MRI, we also have to remember the risks associated with sedation and anesthesia in young children, as well as concerns about CT, MRI contrast agents themselves, such as nephrotoxicity in the developing pediatric kidneys and gadolinium deposition, which has been observed in the brain and body tissues, but we do not know what will be the impact of these deposits in the future. So avoiding these agents whenever possible reduces both immediate and long-term risks in children. Now about the intravesical use of ultrasound contrast agents, 25 years of data in more than 15,000 children have shown no major adverse events from this route of administration. Minor events have been observed in up to 0.3% of children, such as dysuria, urinary retention, abdominal discomfort, and others seen in the table on the right. The vast majority of these symptoms are self-limited, and their type and frequency is similar to what we see with conventional fluoroscopic and nuclear reflux studies. So these mild symptoms are thought to be related to the use of the catheter that we need to put into the bladder in order to administer the contrast agent. Coming now to our institutional experience, here at the Children's Hospital of Philadelphia, we began using contrast-enhanced ultrasound back in 2013. To date, we have performed over 3,000 pediatric CEUS exams, making us likely the largest pediatric CEUS center in the United States. Of these exams, about 1,500 were IV CEUS exams, about 1,000 were intravesical CEUS exams, and about 400 were other procedures such as interventional radiology as well as intralymphatic applications. As Dr. Darge highlighted, it is important to say that in our hospital, we have significantly expanded the use of ultrasound contrast agents across a broad range of off-label indications. We routinely perform CEUS for literally every organ system from head to toe and across all pediatric age groups, from preterm infants to young adults. Many of our patients undergo multiple CEUS studies over time, so we have a great variety of uses and pediatric age groups. In our practice at CHOP, the safety workflow we follow is that prior to the scan, of course, we identify the child, we confirm the order, and review the clinical history and target lesions, looking ahead to what lesions we are looking at. We have a screening form for the ultrasound contrast agents, just like we have for CT and MRI, and we are doing the same kind of screening. We specifically ask about prior reactions to ultrasound contrast agents or other medications. We do ask them if they have ever had any problem with bowel preps or laxatives, trying to screen for the issue of prior PEG exposure or PEG allergy that was recently specified as a contraindication for Lumazon and Definity. We are aware that PEG allergy might be an issue, but it has never come up if this is the case so far. But we do ask the question. For intravesical exams, the bladder catheter is placed by specialized fluoroscopy technologists, and our trained sonographers administer the contrast intravesically, and they are doing the studies. When it comes to intravenous applications, the workflow is similar to what we do for CT and MRI. For outpatients, the IV lines are typically placed by nurses from our sedation unit. For inpatients, ward nurses are usually the ones placing the IV. And the contrast injection is then performed by either our sonographers or nurses if they are present in the room. A pediatric radiologist or a fellow is always in the room to supervise the study and review findings. So in the room where CEUS exams take place, we have a cardiorespiratory monitor and a blood pressure cuff available at the time of the exam. The patient is not necessarily on the monitor unless there is an underlying condition that requires continuous monitoring, such as ICU patients, but the monitors are always available in the room. Wall oxygen is also available, and suction canister is also on and ready. In addition, a dedicated resuscitation cart is in the corridor just outside the ultrasound room. It is important to remember that we need to periodically check and restock emergency medications, such as these drugs often expire before they are ever used, simply because adverse events during CEUS are so rare. Another important thing is knowing what number to call when calling for a crash code. At CHOP, we are a hospital-based practice, so we are calling the internal code team. But in general, this really depends on the environment where people practicing. For example, in a private practice or outpatient settings, it might mean calling 911 and using the resuscitation card on site. So being familiar with institutional and regional guidelines for emergencies and knowing what number to call in case of an emergency is crucial. So at Children's Hospital of Philadelphia, during our 12 years of experience and over 3,000 pediatric CEUS studies, we recently encountered 2 serious anaphylactic reactions in a 3-year-old girl and in a 4-year-old boy after having IV CEUS, the first child for renal imaging and the second child for liver imaging. Both children developed the typical symptoms of anaphylaxis, which were recognized immediately by our team and managed promptly, and both children recovered fully. In this slide, you can see the incidence rate of serious adverse events in our practice, 0.13% with the IV use and 0% with all other routes of administration. Finally, I would like to highlight a recent joint publication in the field of safety by our department at CHOP and Johns Hopkins Hospital that focuses on the use of intravenous CEUS in critically ill children. That means children in ICUs, including neonatal ICU, pediatric ICU, cardiac ICU, children on ECMO or receiving multiple medications who have been given ultrasound contrast agents. In this joint study across both institutions, no serious adverse events and no significant change in vital signs monitoring were reported in this very specific population of critically ill children. So, to conclude, contrast-enhanced ultrasound is a well-tolerated exam, and ultrasound contrast agents have a highly safety performance. With the intravenous use of ultrasound contrast agents, as we mentioned, the incidence of serious adverse events in children is 0.2%, while no serious adverse events are anticipated with intravesical use, which is one of the most widespread applications of ultrasound contrast agents in pediatric population worldwide. Developing a culture of safety within the ultrasound department is critical to ensure optimal outcomes and minimize risks when performing CEUS exams in children. This safety culture is directly related to engagement of all medical personnel involved in CEUS exams, screening patients for a history of allergies, immediate access to emergency equipment such as resuscitation cart, staff education and training on medical emergencies, and familiarity with institutional emergency protocols and response workflows. And with that, I would like to thank you for participating and happy to take any questions at the end of this webinar.
Thank you very much, Katerina. I'd like to next invite Dr. Finn Srinivasan, who is a pediatric interventional and diagnostic radiologist, and he was going to be discussing institution and applications of contrast-enhanced ultrasound in interventional radiology.
Thank you very much, Dr. Beck. Hope my screen is coming through okay. So interventional radiology was initially called special procedures, and I'm highlighting with the use of CEUS a very special set of applications within the realm of special procedures. So this is the outline of this talk. First, we'll talk about considerations of CEUS and with particular why we would consider using CEUS in pediatric IR, move on to discussing techniques and best practices in performing CEUS, just how you institute it. The first point is why we would do it. Second point is how we would do it. And the third point is illustrated examples. I'll take you through just a cross-section of some of our experience with CEUS across major procedure categories. So first point, why? The rationale for CEUS in pediatric IR is based on the fact that pediatric conventional radiology already uses ultrasound as a dominant method for guidance. There are numerous reasons why this is so. This is a dominant image-guided practice with ultrasound, mainly because patients are small. You can use linear transducers, high-resolution transducers for superior spatial resolution. You also get excellent temporal resolution. You can image in non-orthogonal planes with ultrasound. And you can also go off-site and do these procedures portably, say at the bedside. All these advantages are coupled with the fact that CEUS is already a mainstream diagnostic modality, as the lectures you already heard earlier in this session. And so To the standard grayscale ultrasound guidance that we use in pediatric IR, CEUS will add increased contrast resolution. It also allows us to characterize perfusion with excellent temporal and spatial resolution. Ultrasound contrast agents also have very favorable safety profiles, as you've heard in a prior talk. And all of these aspects allow us to use CEUS without significant impediments. We should also keep in mind that our patients in IR are already under anesthesia and they already have IV access established. So those logistical hurdles have already been addressed. So there are two big paradigms of CEUS in pediatric interventional radiology. One is intravascular, where we assess perfusion, and in the intravascular realm, we use applications for intravenous administration of contrast, selective intra-arterial administration, also intralymphatic. And then the second big category is intracavitary, where we assess the distribution of the contrast agent within a cavity. And all of these points are used for problem solving during the procedure. It can be used for in-procedure guidance and also for post-procedure management. Regarding the best practices in the institution of CEUS and pediatric IR, I just would like to refer you to these two articles. I'm not going to spend too much time on these due to time constraints, but they are available for your reference. But these are the highlights of instituting CEUS and pediatric IR. For intravenous use, you would administer as a suspension a standard dose of 0.03 milligrams per kilogram of your suspended contrast agent. In this case, we use Lumason in our institution. We also will follow this with a saline flush and repeat as necessary. For intracavitary use in IR, we just use a 1% suspension, 1% dilution of that suspension in normal saline. For intra-arterial use, that's comes to about a 5% dilution. And then finally, for intralymphatic use, we use a undiluted suspension injected into the lymphatics. And I'll show examples of this later on in the talk. As Trudy has shown you earlier in the session, we use aseptic technique and then inject the bolus through a three-way connector. The inline connector has a contrast agent hooked to it, and then the 90-degree orthogonal connector allows you to flush through the access. And we should also keep in mind that we do not use these hemostatic valves on our connections. We just connect straight to the port. And this is a picture of how we would perform CEUS and IR. We have technologists assisting with injection, while the radiologist would do the ultrasound, and the choice of transducers here is based on the depth of tissue or the kind of tissue you're going to image. We can use curved array transducers for abdominal or pelvic applications, linear transducers for superficial applications, and then intracavitary probes can also be used in certain cases. Regarding settings, not too much in heavy detail here. The default settings are usually adequate, and we image in dual screen mode and then save cine clips. Some basic points and more detailed settings to remember is to keep your mechanical index to be low, which is usually the default setting, and then set the gain so that the pre-contrast screen is black, and then the focal zone is set deep to the target tissue that you want to image. Moving on to applications. In the intravenous category, this is a very nice review article in Radiographics, again for your reference, and it summarizes our experience in intravenous CEUS. But these are the big four categories I'll be covering. One is percutaneous biopsy for lesion characterization, tumor intervention to assess adequacy of treatment, assess vessel patency and hemorrhage, and finally, delineation of lesions in vascular malformations. With percutaneous biopsy, the two big categories here are assessment of tumor necrosis and then aid in lesion conspicuity. And these articles, again, support the application CEUS for these reasons. One example here is a large tumor in a 10-year-old male. came to us for biopsy in IR. Initial biopsy was done with grayscale ultrasound, but ended up being necrotic. Patient returned for CEUS, and we could really see the central areas of necrosis, and we were able to avoid that when we repeated the biopsy with CEUS guidance, and then that ended up being diagnostic for rhabdomyosarcoma. Another case with lesion conspicuity, you can see on this grayscale image that this lesion on the liver that was meant for biopsy is not very well seen. But when we give CEUS, it really highlights how easily you can see the lesion, and then enabled a pretty straightforward biopsy in this case. For tumor intervention, the example I have is a case of ethanol ablation of a metastatic lymph node after thyroidectomy in a patient with papillary thyroid carcinoma. This was before ethanol ablation, where we give CEUS intravenously to assess perfusion of the lymph node. We ablated the lesion with alcohol, and then immediately followed with CEUS again to show that there was no perfusion. This gives us a very good endpoint for ablation in cancers. Regarding vessel patency, this is a nice example in the attached article here that indicated a patient with acute liver failure. Very hard to tell if the portal vein was thrombosed or not in this patient. Even with power Doppler, we're not able to detect any flow going through it. But with CEUS, it was very sensitive for flow. We were able to show that there was flow within the main portal vein and avoided a intervention for portal thrombectomy. And finally, with vascular malformations, we use it to delineate lesions, as we show here. This is a 10-year-old male with the venous malformation of the lip here. One of the key points with sclerotherapy treatment of these venous malformations to delineate outflow veins. Somewhat hard to do without CEUS. This indicated when the outflow vein here highlighted in the oval. We injected the lesion, and then we saw the outflow vein. And following that, we were able to macerate the outflow vein with a needle, because we were able to see it so well in the superficial soft tissues with CEUS. And finally, regarding hemorrhage, this is a patient with hepatic pseudoaneurysm after trauma. We were able to demonstrate a pseudoaneurysm within the liver and went on to embolization. Moving finally on to intracavitary applications, we are distributing we are assessing the distribution of a contrast agent within a cavity. There are a few indications for this with multiloculated connections, assessing fistulae, assessing drainage from an obstructed system, and then to aid in access. Again, these applications are again summarized in this review article. This is a patient, here, with the shoulder lymphatic malformation. It ended up being a very loculated collection. We use CEUS to assess which areas were filling and which areas were not filling to guide appropriate access for sclerotherapy. Moving on, this is to characterize fistula, 18-year-old girl with CEUS abscess. The abscess was drained, but we noted that there was a fistula coming from the abscess cavity into the tumoral ileum, and this was followed with CEUS at bedside to guide appropriate termination of drainage. Finally, with the patient who had suspected biliary atresia, we were able to do a cholecystocele angiogram with CEUS and demonstrate patency of the system. And this is another indication for aiding access, where you can use CEUS to drain non-dilated collecting systems with percutaneous nephrostomy. And the final indication here would be for interlymphatic. I'm not going to spend too much time on this, but with interlymphatic access, we are able to inject CEUS into lymph nodes and assess egress within the lymphatic system from the lymph node. And this is, for example, done just prior to MR lymphangiography to get access. There's another indication to assess patency of the thoracic duct here. Contrast injected intrainguinal lymph nodes and then followed up the thoracic duct, and you can easily see contrast pouring into the subclavian vein to indicate a patent thoracic duct. CEUS can also be used to localize leaks within the cavity, within the peritoneal cavity in a patient with chylosocietes. So in conclusion, CEUS is easy to perform in pediatric IR. It has myriad applications, intravenous, intracavitary, and interlymphatic in particular. It can be used for problem solving and for procedure guidance. It will be good to have more experience and publications to validate the use of all the applications I highlighted, but it can easily become an essential tool in pediatric IR. The barriers for institution in pediatric IR are quite low. But thank you very much for your time.
Thank you very much, Vin. I'd like to next invite Mike Convery, who is a lead sonographer and also the contrast lead in the echocardiography lab at the Children's Hospital. And he's going to be talking about ultrasound enhancement agents in the pediatric echo lab.
Thank you. Can you hear me okay?
Yes.
Got it. Okay, sorry about that first slide. So thank you for inviting me and letting cardiology join your party. Pediatric cardiology especially is a little late to the game when it comes to using these agents. I'm Mike. I work with these radiologists here at CHOP. I have no disclosures. What I hope to get through to some of you guys today is why would you want to use an enhancement agent? What clinical considerations should you be asking and what can you expect to be answered? Do you have the right equipment? And then the inpatient versus outpatient considerations. Communication is going to be the common link to trying to get to your answer for all these objectives. The clinical considerations, the why am I ordering it? Why should I order it versus other tests? The setting up the ordering and the reporting for something like this, if you don't already have it, can be tricky. And then again, I'm going to reiterate the inpatient versus outpatient. That's going to come up a couple times. Education and training is very important for this. We don't do near the volume of these that are done in radiology. So setting up education and training is very important, along with having ready resources for people to refer to. And then the delivery. I'm going to spend some time talking about the equipment and then delivery for this, because with pediatric cardiology, there's definitely some things you have to consider if you're not already doing this. So most commonly, in the adult cardiac world, and even in the pediatric world, left ventricular opacification is the most common use for any of the enhancement agents. You can see the enhanced image on the left clearly shows the endocardial border than the non-enhanced image on the right. So we have a patient population where we might not have as good acoustic windows as we would like, and this is a really good tool. Another area to look at native anatomy is our branch pulmonary arteries. So this image here on the left, the unfocused one, is the main pulmonary artery bifurcating downward and to the right, which is going to screen left, and then the LPA. And if you look at the origin of the LPA and the MPA, you can see a little bit of a, is that real? Is that artifact or not? And this was a nice case where we were able to use an enhancement agent to clearly show a widely patent LPA and possibly avoid another procedure for this child. This was a small child on an oscillator. That's why you're seeing all the movement and the bifurcations. But where we're starting to really make our mark with some of this is we've had some publications. We have what's called a single ventricle pathway. So children that don't have two functional ventricles in the heart to provide either blood to the lungs or blood to the heart, we have to rearrange their plumbing to sustain them through a series of operations to keep them going. This is what's called a Glenn shunt, or a superior cavopulmonary connection. So I'll use the word Glenn from now on to make it easier, where we tie the SVC into the native RPA, which will then provide blood flow to the lungs. And if you look at the image on the top right, you can clearly see a nice widely patent flow coming down the SVC into the RPA and going in both directions. The image on the bottom left, we're able to correlate with fluoroscopy. There's a little bit of a narrowing or a pinching right where that anastomosis is. But then even more importantly, on the right, we don't show flow going out towards the patient's LPA. So by ultrasound, we all know it's very hard to say, is there not flow because I'm not seeing it, or is there not flow there? And with the enhancement agent, we were clearly able to see and then verify with fluoroscopy that there, in fact, was no flow heading down to the left main pulmonary artery or left pulmonary artery. I'm very big when we start this program up on the nomenclature. And I try to avoid using the word contrast around people that don't use this very often, because when you say contrast, their mind automatically goes towards one of the other agents that you guys might use in radiology. So I really try to get my staff to use a word like ultrasound enhancement agents instead. You guys have been well documenting on what these are, so I can go through with this. If you're starting this up in a pediatric lab, and this is where we had to start a little over 2 years ago, we had to start all the way back at IRB approval, consent, how do we reimburse, how do we bill? Then we went into the why would we want to do it for LVO pacification, vessel delineation, even coronary perfusion. And then luckily, because you guys have such an outstanding department here at CHOP, in the formulary, you guys already had access to it. So that really helped. And then we were able to move on to our team building, which included the sonographers, fellows, cardiologists, and then the pertinent nursing staff. For sake of time, I'll go through this. There's 3. We do use the off-label use for these. I just showed you the stuff for the branch pulmonary arteries and the Glenn anastomoses. So we've had to deal with consents and things along those lines, but it's worked out very well for us. I don't want to make this a physics talk, but this is important, and I'll get to that in a second, of pediatric transducers for cardiology are very specific for what we need to do. In theory, with any type of ultrasound, the higher the frequency you're going to use, the better you're going to resolve, and you want to use as high a frequency as you can. To avoid bubble cavitation, we're going to lower the MI. And I'm saying that because we want to use the highest frequencies we can. So since they're nonlinear refractors, they make that nice harmonic resonance, the microbubbles, and just focus on that first harmonic there on the left. If you compare that to the tracing that I made there on the bottom, that's what the harmonic reflection looks like coming back. The machines will electronically use things like pulse wave inversion and amplitude modification to remove that first harmonic, and that's what gives us that really nice black and white look. So the tissue effectively goes away and we're focusing on the microbubbles. So why that matters is, depending on the vendors, the pediatric transducers do not have the factory built-in contrast button that I have set on right there. So if you're going to try and use a high-frequency transducer, and somebody has a suggestion of, let's just turn down the mechanical index to avoid cavitation, you will avoid cavitating of the bubbles, but the image will not be as beautiful as using a contrast setting where you're going to do things like turned on pulse wave inversion. So when you start making these protocols and these settings on your machine, be aware you might have to scan at adult transducers with adult settings that have the factory contrast settings on the machines. We've played with it a couple different ways. You can do it with higher frequency transducers, but we've had better success making our presets with the adult transducers on a cart that has a contrast setting, and then just being able to adjust our depths accordingly. The vendors have been helpful with us. They've given us some cheat codes to try and turn on pulse wave inversion manually, but it hasn't had the same effect yet. And education, I'm just going to echo what Trudy said. You can't have enough education, but I'm even better on having laminated cheat cards in readily available places so you can refer to this. We don't do these as often as other people. So having ready reference material for how to administer it, how to activate it, how to place the order, and how to report it is all going to be very, very helpful to your staff at various levels. Okay. This is the slide, IV access. I come from a department where a lot of our providers take a lot of pride looking at the children and saying, when you come visit me, you're not going to get a needle. They say that a lot to try and calm kids down. So this is where the inpatient versus outpatient access has come in for us. And this is probably the biggest hurdle we've had to overcome. With inpatients that already have IV access, the considerations are now a clinical consideration of, do they have an IV access? Where is it? And is it big enough? But more importantly, the location of that access matters, because if we're looking at shunts that we've placed in the upper extremity where we've moved the venous plumbing around, depending on what anatomy you want to opacify in the heart, depends on where you're going to put that IV. If there's like a lower extremity IV access and we want to look at an SVC connection to the branch pulmonary arteries, it's not going to help you out much. or if there's bilateral versus LSVCs, which is the type of patient population we're working with. That's just something you have to be aware that if you're going to do this and you're going to push it through an IV, that flow will get to the anatomy on what we like to call the first pass. So we want to see it actually injecting into there before it's systemic through the entire circulation. Now, the outpatient side, starting IV access in the outpatients is a hurdle that we're working at to overcome. We require things like the IV start team to come over. That's going to take time to add to the study. Our sonographers, as well as the nurses over on the outpatient side, do not place IVs. So I'll say it's a work in progress. We're successfully doing them on the outpatient side, but when it comes to planning, scheduling, and team communication, I can't emphasize enough the importance of the IV and making sure that the parents know before they come on site that this is something that they're going to go through, because they may have had dozens of echocardiograms before, and now somebody's telling them they need to get an IV. So we just want to make sure that that's something people are aware of. What I circled there on the right is we also administer pregnancy tests to all the girls of appropriate age that come through for us too. So that's something else that's going to require timing, orders, and communication, and things along those lines. I learned a lot about ICUS today, which is, I am very happy, and I'm going to make myself a more frequent visitor of those websites because they look like some pretty awesome resources. Here are some other resources that I have that are going to be much more cardiac specific. Feel free. And I think that is all I really have today, and I'll be happy to answer any questions during the question and answer period. Thank you very much.
Thank you very much, Mike, and thank you to all of our speakers and their wonderful presentations today. Now I would love to open up the discussion to questions coming from anybody who has been listening online for topics that have been covered or other questions that you might just have in general. While we're waiting for the questions, can I ask, Mike, in your section, do all of the echocardiography technologists perform contrast, and do all the cardiologists who interpret echo interpret contrast?
That's a fantastic question. The answer is yes to both, with varying experience. If on the cardiologist side, I can't speak if they all have done it, but we do not change our schedule based on who's the reading cardiologist that day.
Thank you.
And I also ask Michael, the contrast software that you're using, is that the one with a color overlay, or you only have the black and white ones?
So we only have the black and white ones. We don't have, the cardiac world's a little lagging behind you. We don't have as many cool toys as you guys have when it comes to the ultrasound enhancement agents.
So the software from the ultrasound maker, they don't offer the color overlays in the in the machines that you use. Okay. Good.
No, they do not.
Understood. Yeah, I mean, we used the black and white ones. I mean, then they came up with the color overlay, so that's fine. Thank you.
There is a question in the chat. Oh, no, sorry, pardon me. This person did start off to say that they don't have a question, but they are thankful for the sharing of knowledge and experience. So thank you very much for that comment. A question entered into the chat says, what about the problem of the movement? Is that specific to heart motion, or is that a question about body imaging or other parts of the body? I guess I can answer that just from a body imaging perspective. And Mike, if you want to jump in about echocardiography, I think we're able to move with kids as much as we can with diagnostic grayscale ultrasound. Abdominal examination is a clarification for the person who answered the question. I think that we try to just have children breathe regularly and try to move with how they move. Obviously, that can be challenging if they are crying and therefore breathing rapidly. Most challenging if you're at the dome of the liver or someplace that may pop out of the field of view. We try to check our positioning with the transducer before we administer contrast and get a sense of how that lesion or area moves. Keeping your probe in a long axis relative relative to a lesion is helpful because you have a greater footprint for that lesion to slide with respiration. But I think typically if we're capturing a cine loop in that first minute or so of contrast enhancement, we can see enough points in time to know what is happening with that lesion. But certainly some areas can be more challenging than others. We typically try to remove the probe from the abdomen after that first minute and come back periodically to see how that lesion, how the contrast persists or washes out from that lesion so that we don't artificially burst bubbles. But I think sometimes when those lesions are hard to see or hard to stay on, we may keep the probe on longer, and we just have to be mindful that we might be facilitating bubble destruction just by the prolonged visualization.
Right. So one thing I want to add, we have the luxury in IR, the patients being completely asleep. So on occasion, we have done diagnostic CEUS, prior to, say, a biopsy, for example. It does help to have the child calmer, and I've seen, the difficulty in when a child on the diagnostic side, when the child is really agitated to try to follow these very small hepatic lesions to characterize them. One option is oral sedation, like oral midazolam, that might be very helpful in calming the child to be able to do the study in a more controlled setting.
That's an excellent point. One question that we get not infrequently is about our voiding examinations and about whether we sedate for those. I think we apply the same principles as we would for a VCUG, where we try not to sedate and use the non-sedative approach with child life and distraction techniques. But as you're saying, Finn, there are some children who need the sedation for a number of reasons. And so doing just as you suggested, so giving a sedative that is not an anesthetic that sort of knocks them out or still permits them to void volitionally, especially for that particular exam, is very useful. And we, again, engage the same assessment as we do for our other exams in the department, where the referring provider raises a question that the child might need sedation, so we have a nursing intake, or when the family is contacted to schedule our triaging of scheduling patients, they ask patients of a certain age, or the parent brings up if there are other conditions where they think their child might need it, so that we can facilitate the ordering and scheduling to meet the needs of that child and family. Thank you. And thank you for that question about motion.
Sue saying that that's where child life could come in hand. And also we've had times, especially for our IV cases, where parents can lay on the bed with the patient. And sometimes just that comfort of having mom or dad next to them can, alleviate them from moving and getting upset. And sometimes that helps.
Thank you, Trudy. That is excellent. Having that close proximity, not having a fluoroscopic tower or a family member needing to be put lead on to sit in CT or have MRI clearance to sit in the magnet are all things that help facilitate workflow and safety in our imaging department. The next question that has come in asks, how do you see the future of using contrast-enhanced ultrasound in emergency medicine?
So what do we say about that? We have started contrast ultrasound in emergency medicine. We work hand in hand with one of our attendings down there, and we have done research, and we have done trauma patients, trying to see if we could come up with the same answers that CT does. So yes, I do see maybe going down the line that this would be a more useful tool coming along.
I just want to add that, first of all, there are a number of comparative studies have shown that CEUS for blunt abdominal injury is really helpful and is comparative over or even better result than CT. So that in that light, it's something that one really has to think of using it, and especially the fact that you don't need a dynamic imaging, but only look for any damage after the organ is enhanced, makes it a much simpler exam compared to a dynamic exam for a specific liver lesion. In addition to that, we have to remember there is an advancement in point-of-care ultrasound by done by ED physicians even in the pediatric ED setting. And we have been collaborating from the beginning with our ED physicians with the point of care ultrasound to be involved in this and also take the responsibility of doing some of these studies themselves under the point of care ultrasound setting. So there is a huge potential of expansion. Why is that we push for our ED physicians to do it? Because it's a 24/7 exam that may be needed. And we certainly want to expand the manpower who are available to do it. So having them do point of care ultrasound as part of the imaging and support the service is very important. So in terms of having it in point of care, radiology also doing it, certainly there is a big potential of contrast enhanced ultrasound expanding in the emergency medicine.
Thank you, Casa. There are other questions from the audience. Any other questions or points that the panelists would like to raise?
Yeah, real quick, I forgot to bring this up in my talk, but with communication, and you guys were talking about motion, if somebody's trying to get a contrast and enhanced echocardiogram because a previous unenhanced echo was limited, and those limitations were things like uncooperative patient, surgical dressings, things along those lines, that just ordering a study for this will not overcome those limitations. Ultrasound physics still apply.
That's a great point, Mike. I think we always like to say if we can't see it with ultrasound, we can't see it with contrast ultrasound. So we have to be able to have the right window. And as you and Finn have both brought up, we have to have a patient that has some buy-in, although we understand that different phases of development and different disease states might make that more or less at will for the patient.